Hi everyone, and welcome to episode 5 of Dysphagia Matters, evidence-based talks with Julia and Jule. In this episode, we have Margaret Walshe as our guest.
Dr. Margaret Walshe is an associate professor in Ireland at Trinity College Dublin in the Department of Clinical Speech and Language Studies. Her special interests comprise the assessment and intervention in acquired motor speech disorders and in neurogenic dysphagia. She was both our supervisor of our postgraduate dissertations and still is Julia's PhD supervisor. So we're really happy to have her on today's episode, also because initially it was her idea to start this podcast. Welcome, Margaret.
Thank you, Jule and Julia. Gosh, yes, I have a lot to answer for, don't I, with my lofty ideas on podcasts.
Yeah, I mean, it's a great idea and it really got us started. We're happy to have you today on our episode. Basically, this episode will cover all things related to screening of swallowing and swallowing disorders. We would like to give you an insight of when and why we need screening, who should and can screen, and what screening results do tell us or what they don't tell us. Margaret, would you mind starting the conversation by explaining what screening is?
Okay, well, screening to me is the first step in the diagnostic process for dysphagia. And it's typically fast. It identifies risk, and I think the word risk is important. The risk of having dysphagia or aspiration, and these tests are typically seen as a pass-fail test. There's a nice definition that I used from ASHA in 2009. They're a special interest division group, and they define it as a minimally invasive evaluation procedure that quickly helps to answer 5 key questions. So the questions are, what's the likelihood that dysphagia exists in this person? Does the patient require referral for further swallowing assessment? That's the second question. Thirdly, is it safe to give the patient food or fluid orally for the purposes of nutrition and hydration? And the fourth question is, can we administer medications orally? And that's really often a very critical question when somebody comes in who is acutely ill. And finally, the fifth question is, does the patient require a referral for nutritional or hydrational support? So this screening test really, its purpose is to just help us answer those questions very quickly. Patients who identify as high risk and fail a screening test should go on to have a more detailed swallowing assessment. So as I say, for me, it's just maybe the first step in the diagnostic process for dysphagia.
Yeah, okay, great. And you've already mentioned that the assessment afterwards is more detailed. Could you maybe explain a little bit what the difference between a screening and a clinical swallow evaluation is?
Oh, gosh. Well,
just briefly.
Yes, no, that's fine. I would see the clinical swallowing examination as being much more comprehensive, that it's completed by an expert in dysphagia. The screening test could be completed by frontline staff, so by nursing staff or by medical physician, by somebody trained in swallow screening. Whereas the clinical swallow examination, I would see as really being completed by an expert in dysphagia. And it typically involves, a detailed case history or a motor examination, trials of different food or fluids, trials of compensatory strategies. So it's not a pass-fail test, but it's a much more comprehensive assessment. And then it may lead on then to an instrumental assessment. But having said that and described a clinical bedside evaluation like that, some screening tests like the VVST, for example, and the GUS, they're fairly comprehensive. They call themselves screening tests, but they're fairly comprehensive. And so we probably need a consensus on what we mean by screening or by dysphagia screening.
Yeah, and as soon as the screening is comprehensive, it means it takes longer and it needs more training. So it's more complex to conduct.
Yeah. And I think it depends again on, sometimes because it's so comprehensive, it can't be done by frontline staff, and I think if we want screening to be something that's quick, easy, and is and will identify the target condition. Now, I suppose I haven't said anything about that in my definitions of screening and of clinical swallowing examination. But, some screening tests, particularly the water swallow tests, the target that they're looking for is aspiration. Whereas the target condition in a clinical swallow examination, I'd see is beyond aspiration. It's looking for the presence or absence of dysphagia and maybe looking more at how compensatory strategies work, and how you can manage the dysphagia a little bit more. Whereas I think after the screening, if the target is aspiration, it's often, to give oral intake, yes or no. It's kind of that binary decision at the end of that.
Yeah, and that explains why you really need to be a swallowing or dysphagia expert to do the assessment instead of the screening. So you've already mentioned that everyone can do the screening, or every healthcare professional who is trained in doing screenings. Would you say that we as speech and language therapists should or can do screenings as well?
There's no reason why we can't do screenings, but I think by the time we see patients, we need to do more than screening. So, why would we do screening when we can do a full comprehensive assessment? So we might incorporate elements of screening tests. So, water swallow tests might appear in part of our assessment, our clinical swallowing examination. But I'd see screening as something that could be done by non-speech and language therapists. So, frontline staff, when a patient comes in through accident emergency after stroke or traumatic brain injury or an acute neurological event, for example, or even if they come in with a dementia, whoever comes in through those hospital doors needing acute medical care, but who is likely to present with dysphagia, then I think, one of the medical team or nursing staff could do that screening. Equally, GPs and GP practice surgeries could also do screening. So I think when they come to us, we really tend to do more than just the screening.
Okay, you've already explained some patients who might be at risk of having dysphagia. Can you maybe explain that a bit in more detail? Who are the patients that need to be screened?
Anyone who presents with a risk who present with a condition that's associated with a high instance of dysphagia, or patients who have already report some signs of swallowing impairment. I think people who have a history of dehydration and malnutrition, who have ongoing respiratory issues that are unexplained, people who have a history of choking. So the history, I think, is very important in terms of dictating those people or those patients that need to be screened. But I suppose it's important to say that screening may not be enough. And for these patients who come in with a history of these type of difficulties or these consequences of a possible swallowing difficulty, that it might be best to go for a full bedside examination that may or may not be followed by an instrumental assessment.
So you mean skipping the screening and directly going to the clinical bedside evaluation? Yeah,
I give one example, I think, of one of my patients that she was an 83-year-old woman who was admitted to hospital for her 5th chest infection in over a year. And she'd had a right hemisphere stroke about 3 months before her first chest infection. And she'd been briefly on a stroke unit. And her difficulties were predominantly physical, as it was seen at the time. But she was screened for dysphagia and she had no overt signs of aspiration, although her daughter thought that she had some difficulty at home. So because she'd had 5 chest infections, we did a videoporoscopy on her. And on that videoporoscopy, she had silent aspiration on fluids. So we modified her fluids, and she was really happy to do that because she was quite distressed about her frequent hospital admissions. She just wanted to get home and get on with her life. But her respiratory issues resolved. So without a doubt, I think the aspiration was contributing to her respiratory difficulties. So this is an example of where screening is often not enough. We can get false negatives. So, and particularly when a patient has silent aspiration.
Okay, and you've already talked a bit about the stroke unit. In some countries, it's within 24 hours or 48 or 72 hours, a patient needs to be screened for different things. Do you think this would also be important to have for more general population? When should we screen?
I think it's a hard question to answer,
Sorry.
No, I'm saying, but when, because, the guidelines for stroke are very clear, because the evidence is very strong that if you screen patients early, if you pick up dysphagia early in stroke, you prevent a lot of the complications that are associated with swallowing disorder and stroke. So when you reduce the incidence of stroke-acquired pneumonia, you reduce the costs, the length of hospital stay and the cost of antibiotics and so on. So early detection in stroke is important. And I suppose, you might screen if you work in a residential setting where new people are coming in with a range of cognitive problems, in nursing homes, dementia, for example. You might at the point of entry do some screening as well. The same with residential facilities that are for people with intellectual disability who come into residential care. So screening at that point of contact might also be useful.
So this stays a difficult question, or it's an individual decision to be made. So depending on the population, if they have a risk for dysphagia, and then depending if it's acute or not, or if they're new to, for example, the residential care facility. So could we summarize it like this?
Yeah, absolutely. And I think in stroke and stroke guidelines, the recommendations are very clear. The paper published by the European Stroke Organization and the European Society for Swallowing Disorders have a very good paper on clinical guidelines for the management of dysphagia post-stroke. And one of their key recommendations, or the first recommendations, are that in all patients with acute stroke, they recommend a formal dysphagia screening test to prevent post-stroke pneumonia and decrease the risk of early mortality. And they recommend screening patients as fast as possible after admission. They also recommend for screening that there are either water swallow tests or multiple consistency tests might be used. But we don't really have those guidelines for other conditions like Parkinson's disease or motor neuron disease or the other progressive neurological conditions. They're not as clear. We don't have as clear a protocol.
And so if I decide in this specific situation or this specific patient population, I do need a screening, how can I then choose the best available screening tool for these patients?
Another difficult question, Julia. New screening tests are coming on board all the time. And I think, the answer depends on who your patient is and the context in which you work. And maybe the best way of answering the question is perhaps to give some key principles that will guide selection. So I would say that first, maybe to choose a test that has a high level of diagnostic accuracy for the population that you're working for. So look for a test that has already been validated against an instrumental test. We call these our reference standard tests. And in dysphagia, we just have two reference standards or gold standard tests, which is FEES or video fluoroscopy. So if your screening test is focused on aspiration, then you can look for a test that has been validated against video fluoroscopy or FEES, because both of those instrumental tests are largely reliable to detect aspiration. But if you want a screening test that aims to detect the presence of dysphagia beyond aspiration, then you really need to look for a test that has been validated against video fluoroscopy. So you've got information on the oral phase, difficulty at the level of the pharyngoesophageal phase, and so on. So that first point, to choose a test that has a high level of diagnostic accuracy. The second thing is to choose a test that's been validated on the population that you're working because tests work differently with different populations. So most of our screening tests are validated on patients with stroke. Now, the TORBEST is an example. So you need to look and see what screening tests are available for your population. So we have, hardly any screening tests that have been validated on the frail older person, for example. So that maybe is the second point. And the third point is to when you're choosing that screening tool, you need to train the person who will be administering screening tool. That's important. And most of the screening tests with strong validity and reliability data, such as the TORBEST, again, have a training element associated with it. So the expertise of the clinician or whoever's performing the test will increase the diagnostic accuracy of the test. So back to your question about choosing the best available screening tool, that seems like hard work, but I've said, how do you go back and, trawl through the literature to find out what the best test is? But there are an increasing number of systematic reviews that have done that work for you. So there's, reviews by Bowden et al. Looking at stroke. Brodsky et al. Have done a very nice systematic review on water swallow tests. So I would say to if you're looking at the tests, go first to the systematic reviews and the diagnostic accuracy reviews to see what work has been done. Somebody has done all the hard work in trying to find, hopefully, the best screening tests and gives the diagnostic accuracy values for different tests and different populations. So I'd say I would start there.
Yeah, okay, great. And so when we read about screening tools, we oftentimes come across the terms sensitivity and specificity. Could you maybe explain what these can tell us?
Sensitivity tells us about how good the test is in telling us that the target condition is present. So the target condition could be dysphagia or aspiration. So we're aiming for 100%, so that we want a test that has 100% sensitivity. So a test that will pick up everyone with the target condition. So a lot of true positives. And we'd hope that no one would be missed. So we want no false negatives, but that's not always possible. So tests with high sensitivity tend to over-identify patients. So you'll get some false positives there, but that's okay because it's screening. And that's okay as long as the test is followed by another more comprehensive one, or is followed by a period of observation. A patient might be placed unnecessarily on thickened fluids because a less than accurate screening test has wrongly identified a dysphagia. That's what we really want to avoid. So we want to avoid those false negatives, like that 83-year-old woman that I just discussed earlier, whose dysphagia was missed on screening. So sensitivity focuses on true positives, and it's a test that will over-identify the target condition. Specificity is the other diagnostic accuracy parameters or constructs. And specificity tells us about how credible the negative results of a test are. So if this test gives a negative result, can we really believe or trust that the target condition does not exist? So specificity focuses on true negatives. And again, that's typically expressed as a percentage. So with screening tests, we're looking for high sensitivity. We'd also like high specificity, but we're not so worried about high specificity in a screening test if we can get good sensitivity. Not sure if that makes sense, but it's difficult to achieve high sensitivity and high specificity. So we usually end up with two tests, one that has high sensitivity, followed by one that has high specificity. And I typically use the example of a mammogram, in breast cancer. That's an excellent screening test for breast cancer. and it's relatively cheap to do, but we know that it might over-identify people. So if a lump or something suspicious is detected on a mammogram on screening because it's got high sensitivity, the patient is referred for perhaps an ultrasound, which is not good high sensitivity, but is very good specificity. It's very good at ruling out something sinister. But like dysphagia, our diagnostic tests follow a pathway, and just one test is typically not enough. So we screen, we rule out, we screen patients with our screening tests, we over-identify, then we rule out with a clinical swallow examination, and then if in doubt, we'll do an instrumental assessment. One thing I'd say though about sensitivity and specificity is that all seems very straightforward, but it isn't. As well as looking at sensitivity and specificity, there are also values such as predictive values and likelihood ratios, so to complicate things further.
Yeah, thanks so much for starting to differentiate these terms. So sensitivity, how well does the screening tool identify the presence, in our case, of dysphagia? And then specificity, how well does it identify the absence of dysphagia? And this also explains why it's so important to do the screening. If we have a high sensitivity, we really want to catch all of them. But unfortunately, there are going to be some patients that have been screened or did fail the screening. So it is assumed that they have a risk for aspiration, and then they might be put on nil by mouth. But then later on, through our assessment, we can find out that they aren't at risk and that they can eat any consistency, any fluid. So now you've already mentioned the term, the predictive value. Could you explain what this has to do with the screening?
Okay, well, that's a good question, because very often people just focus on the sensitivity and specificity of a test. And, when you read the literature on this, you'll see that not only is information given on the sensitivity and the specificity, but also on the positive and negative predictive values and the positive and negative likelihood ratios. So I won't get bogged down on these here, but I think it's sufficient to know that the predictive value gives you information on how good a test performs if we take chance out of the equation. So tests on sensitivity and specificity are often completed, or the diagnostic accuracy values on sensitivity and specificity are sometimes taken from studies where people are likely to have the target condition. So, for example, a test is done on somebody who's had a stroke. Well, somebody who's had a stroke is likely to have dysphagia anyway. It's highly prevalent in the acute stages. So the chances are that it's likely to come up positive on a test. But the predictive value gives you a little bit more information on how this test would perform on someone who is less likely to have the target condition. So in areas where the dysphagia might be less prevalent. So predictive values takes the prevalence of the underlying condition into consideration. So you've negative predictive values and positive predictive values. So whether dysphagia or aspiration is present or absent. Now, these values depend on knowing the prevalence of the target condition, dysphagia or aspiration, in your population. And so therefore, because we don't have a huge amount of epidemiology data, this is often difficult to calculate. And I'd place more emphasis on likelihood ratios. And likelihood ratios is the likelihood that a given test result, so the test that you get, a positive on maybe the Yale water swallow test, what's the likelihood that this result would be expected in a patient with aspiration compared to the likelihood that the same positive test would be expected in a patient without aspiration. So, for example, you have a patient with stroke who coughs on drinking 30 mils of water. So you find in an article that 90% of patients with stroke who cough on 30 mils of water or fluid also have aspiration. So that's the sensitivity. So it's 90% sensitivity on picking up aspiration on 30 mils of fluid. But in that paper, you also find that 15% of patients with stroke also coughed, but they coughed on fluids for other reasons. So they coughed on that 30 mils of water, but they coughed on for other reasons. Maybe they have an underlying respiratory condition or, whatever. So you have to calculate then the likelihood that taking everything into consideration, the likelihood that this test would be expected in a general stroke population. So the likelihood, if you can calculate that means that your patient's result, so 90% of patients will cough on drinking 30 mils of water, but 15%, so 90% will, but 15% won't. So if you divide 90 by 15, you get 6. And so your likelihood ratio is 6. So it means that your patient's result would be 6 times as likely to be seen in somebody with as opposed to somebody without aspiration.
Great. Thank you so much for that example. I think it's really helpful, especially in this audio version as a podcast.
Yes.
But as you said, it's really important to look at these values. And I think oftentimes we try to push them a little aside because we feel like it's too difficult. But it's so important to actually tackle them and understand what they mean. So thank you so much.
I think the key point there is to look beyond sensitivity, specificity, predictive values only if we have a lot of data on prevalence, but to move on to likelihood ratios and look at the likelihood ratios of a test. And that's often quite revealing. You look at a test and you think, oh, that's really good in sensitivity and specificity. But then you look further down the graph and you see its likelihood ratios and it doesn't look as good as it did at the outset. So it's just, again, we don't have a huge amount of research on diagnostic accuracy. And sometimes our data on diagnostic accuracy, on screening tests and the diagnostic accuracy of screening tests are based on tests that have been mapped not against the reference standard of FEES or videofluoroscopy, but they've been measured against another index test or another kind of test that can be quite subjective. So they're never reliable, really, in my opinion. If you want to get proper diagnostic accuracy data, you have to check that screening test against a videofluoroscopy or a FEES.
Okay, so it's important to dig into the topic and get familiar with all these terms and what they mean and what they can tell us about the screening.
Yes.
To do a good diagnostic.
Yeah.
Okay, I think we've covered the theory on this for now. Let's talk about the actual screening tools and tests that exists. What is out there?
Well, there are a lot, actually. If you look at the tests, there's an awful lot out there, but most of them are not validated, or they're very weak diagnostic accuracy data associated with them. But there are different kinds of screening tests. So they range from asking questions about swallowing. You've got the 4Q test that Zhang et al. In 2020 talk about, which involves asking the person 4 questions. The questions are, do you cough and choke when you eat and drink? Does it take longer to eat your meals than it used to? Have you changed the type of food that you're eating? Does your voice change after eating or drinking? So that's one type of screening test. So these kind of questionnaires, the EAT-10 actually is even though it's a patient-reported outcome measure, it's sometimes used as a screening tool. And we can have screening tools or questions that are part of other general disease-specific tests, like so in Parkinson's disease, the MDS-UPDRS, which is a scale developed to evaluate various motor and non-motor aspects of Parkinson's disease, that has questions also about swallowing, saliva control, and speech. So you can have those screening type questions. So the other types of screening tests are the water swallow tests, so requiring the person to drink various volumes of water. And then you can progress to trialing food and liquids like the volume viscosity test and the gugging swallow screen to determine the risk for aspiration and dysphagia. But I suppose to just consider the questionnaires for a second, one factor to consider in using those to screen for dysphagia is that the person might not always be aware of their swallowing problem. So Nama Siviam MacDonald in 2019 in a NICE study reported that almost 400 older people that they questioned about their swallowing ability, 80% of those who failed further dysphagia assessment didn't report any difficulty. And that might be due to coexisting other conditions, including cognitive impairment in that study. But it's also likely that older people might accommodate changes in their swallowing over time, and that they might attribute their difficulties to aging. So I think that's a problem with just relying on questionnaires alone. But water swallowing tests are very popular in dysphagia screening across all ages and populations, and some have established, good established validity. The target mainly for these water swallow tests, as I've said earlier, is usually to diagnose aspiration. So is the patient aspirating or not? Now there's a huge range of water swallow tests. They might involve single sips of water ranging from 1 to 5 mils to drinking 90 to 100 mils consecutively. And they can involve, protocols that involve timing, so the timed water swallow test. They can have protocols with swallow trials that progress in difficulty, requiring the person to drink increasing volumes of water. And so Brodsky et al. In 2016 did a very nice systematic review on the diagnostic accuracy of water swallow tests to detect aspiration in patients at risk for dysphagia-associated aspiration. And they found that water swallow tests definitely have some merit in screening for aspiration. And they concluded in that paper that consecutive sips of large volumes of water in patients that didn't present with overt airway responses such as coughing, or who didn't present with any voice changes, that was useful in ruling out the risk of aspiration. So good specificity there. Somebody drinks large volume of water, they don't cough, they don't have any voice changes, then they're probably not going to have aspiration. But small volumes with single sips, where the patient had difficulty with those small volumes, so they had an airway response, coughing or choking, with voice changes, they were more accurate in identifying aspiration. So I think that information is kind of useful for us when we're looking at tests. There's all sorts of controversies about the diagnostic accuracy of a wet swallow. If somebody has a gurgly or a wet voice after assessment, does that mean aspiration? And we know ourselves that, when you do videophoroscopy and you see a person silently aspirating, you ask them to say "ah" to vocalize, and their voice is clear. But you've somebody as well who doesn't aspirate, but they've got a lot of residue in the pharynx, and you get them to say "ah," and you have a gurgly voice because you're getting resonance from the pharynx, from the residue in the pharynx. So there is all of that debate at the moment on the diagnostic accuracy of things like a wet voice after tests as well. So we've a lot to learn still around tests.
Yeah, and especially elderly people oftentimes have a wet voice a few seconds after eating or drinking. So it's just a common thing. And like you say, we in these people, we wouldn't assume they have dysphagia or that they would aspirate. So when we do the screening or later on the clinical swallow evaluation, it is really difficult to say, is this now something that I should be concerned about, or is it just their regular habit, how they eat and drink?
Yeah, exactly. And I think the focus is on whether they're symptomatic or not. If they're doing okay, got a wet vocal quality, it could be just saliva, just sitting there and with reduced sensation, reduced audio, they don't hear it maybe as well, they don't feel it as well, and it's just saliva sitting there on the vocal cords. But their chest is clear, they've got no nutritional or respiratory symptoms of an aspiration. So I think, we don't need to intervene with those kind of patients.
So, yeah, thank you so much. I think that brings us to the end already. Did we forget to talk about anything?
No, I think there's a lot of guidance and a lot more research, and a lot more systematic reviews out there now to help people to navigate their way through this and through the whole area of dysphagia screening. A really useful paper here is a recent publication by Spire et al. On dysphagia screening and assessment, published in Dysphagia in 2021. And I suppose the key points that I want to make at the end of this is to remember that you don't base management on the results of one test alone. You really look at the patient in front of you, look at the case history, the comorbidities, the underlying clinical medical condition. Your clinical experience is important here. The training of the person who's administering the screening test is important. Look beyond the sensitivity values when you're looking at tests. Look at predictive values and likelihood ratios, and choose a test that has high diagnostic accuracy for the population that you're working with. I think that's important if it's available. So thank you, Julia and Yule, for the opportunity to talk about this important topic.
Yeah, thank you. Thank you for talking about it. And thanks so much for coming on the podcast. We hope you, our listeners, enjoyed this episode as well. Let us know on Twitter at DysphagiaPcast, on Instagram at DysphagiaMatters, or on our website, dysphagiamatters.org, whether you would like us to continue this topic or not. Are you interested in a follow-up episode on non-instrumental assessments of swallowing and instrumental assessments? We would love to hear from you. Thank you so much for listening. Thank you, Margaret, for coming on the show. Take care, everyone. Bye-bye.
Thank you. Bye.
Bye.